I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenny as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone.
Hello and welcome to the Hormone Genius Podcast. I'm here with Jamie, my co-host, and we're going to talk about a lot of issues related to menstrual cycles today. We have a guest, and we're really excited because this is a guest we've had before. Dr. Monica Minjeur is back with us. She's a family medicine doctor, has an incredible clinic called Radiant Clinic in Cedar Rapids, Iowa. She has so much experience, and she wears many hats. She's fem medical trained. She is NAPRO medical consultant trained and neo-fertility trained, and we're going to learn a little bit more about that today. But our focus today is to really dive into the menstrual cycle and particularly the flow of the menstrual cycle and what is underlying in the menstrual flow that we can learn from and maybe dig deeper, especially if you have suffered with fertility issues, maybe you have miscarriage in your history and you are looking for answers. We are going to give you that today by diving into what we can see in the menstrual flow, particularly in a condition called chronic endometritis. So Dr. Minjeur, thank you for being here today with us on the Hormone Genius Podcast.
Thank you for having me. I'm so excited to be back talking with both of you.
Awesome. So let's just dive into chronic endometritis because that's kind of the main thing we wanted to talk about. Give us an overview of what that condition is and why we really need to look again into the menstrual flow to understand really what is going on in the root of what we see in our period.
Yeah, so I always start off with explaining to my patients chronic endometritis is not endometriosis, right? So these two words are very similar. So I just want to lay that out from the start. So endometritis is inflammation of the lining of the uterus, of the interior wall. And most often it's caused by infection or what we call dysbiosis. So an imbalance of the actual bacteria, the yeast, everything that makes up what should normally be in the uterus. Now, interestingly enough, the uterus is not a completely sterile organ. So we do have bacteria that should live there. And predominantly, we should see a bacteria called Lactobacillus. Now, ideally, Lactobacillus makes up 99% of the bacteria that are in the uterine wall. However, if there is any dysbiosis or an imbalance of that bacteria, we can see other bacteria that can start to set up shop in the uterine wall lining, creating inflammation, infection, and in many cases, this can manifest as infertility, recurrent miscarriages, irregular bleeding. In some cases, we see it can produce mucus that is happening throughout your entire cycle rather than just during your fertile window. And really one of the hallmarks that we look for, and one of the things we'll talk a little bit more about today, is this prolonged bleeding or brown bleeding. Now, it's very common to have brown bleeding or spotting maybe for one day or so at the end of your cycle. But if we're starting to see that space out to 2 or 3 days at the end of every cycle where you're having brown bleeding, brown spotting, that can be a sign that there may be endometritis there. We also can see endometritis in times where there's bleeding at other times of your cycle. So maybe during your ovulation window or leading up to your period. Now, there's lots of different things that can cause that, but we always want to keep endometritis on the radar. One of the things that's really tricky about it is that in order to diagnose it, there's not a simple blood test that we can do, right? So like checking hormone levels, we can do a blood test in order to see where's your progesterone, where's your estrogen. But when we're looking for these infections, it's really tricky in order to kind of sort that out. And I'm assuming we'll get into a little bit more as far as how we evaluate that. But in general, that's kind of what we're looking for is how do we discern, is there infection or inflammation in that lining of the uterus?
So interesting, Dr. Minjeur, because just within the past year or so, I've been hearing more about chronic endometritis, and namely because I have a couple of really close friends who are trying to achieve pregnancy who've been diagnosed with chronic endometritis. And just even as you're explaining, that there's a dysbiosis, an imbalance of bacterias in the uterus, well, of course, that sounds a lot like our gut. We think about gut dysbiosis a lot and lactobacillus and all these things. So these are words that our listeners have heard before, but maybe not as it's associated with the uterus. So can we assume, or might it be a safe assumption that if somebody has dysbiosis of the uterus, that they may also have dysbiosis of the gut? If they work on treating their gut, may that then just also help that infection or that environment of the uterus that needs more balancing? So what kind of theory would you place on that?
Yeah, I think that plays a huge role. And, we're learning more about the gut microbiome playing a role in kind of managing all of the other microbiomes that are in our body. So I think absolutely one of the things we always screen for in our practice is what's going on with your gut? And they're like, what? I'm here for my periods. What are you talking about? Right. But because it plays such a huge role in managing not only hormone regulation, but the microbiome that goes on in other places, absolutely, we need to be looking at this. Now, where it gets tricky is again, the evaluation, the diagnosis of it. And it's, even with gut microbiome, it can be a bit challenging. So we oftentimes will go based on symptoms, right? So if you're somebody who has irregular bowels, whether that's diarrhea or constipation or back and forth or bloating, or, I just feel or look like I'm 8 months pregnant and I'm definitely not, any of those things can be a trigger for us to think, is there something going on from dysbiosis? Now, interestingly, every organ has different bacteria that should be there. And even within the female reproductive tract, the bacteria that are present in the uterus are different than the bacteria that are present in the vaginal canal. And so as we talk about testing and evaluation, we'll learn that just doing a vaginal swab does not tell us what the uterine microbiome looks like, because the vagina is separate from the uterus. And so even though they are related, and the idea of, our bacteria can move to different places in our body, of course, through the bloodstream, there are different areas of our body that should have a different makeup of the microbiome. But absolutely, Jamie, I do believe that there's a huge link between microbiome being off in one place and in another place. And so as we talk about treatment a little bit later on, you'll see we oftentimes say we're going to treat the whole body when we're dealing with a dysbiosis in the uterus.
So if we're going to know so you mentioned obviously like there's signs in our period that would tell us potentially that we have an issue in the uterine lining, and someone is worried about that, whether it be because they have infertility or miscarriage, or maybe it's just that their period they know is not healthy and normal, or it doesn't feel right. And you said we can't just do a swab in the vagina. So how do we get this information? And I know from my experience, a lot of times, like patients had gotten this information, maybe if they had like a laparoscopy or a surgical procedure when they were actually looking in the uterus, that's called a hysteroscopy. But I think you alluded to the fact that maybe we can get this information without that type of invasive procedure, and that there's going to be more options for that. So give us an idea of how we can learn more about what's going on in that uterine lining.
Yeah. So one of the amazing advances that's happened within the last 5 or so years has been that we can evaluate menstrual sample blood. And so literally women will collect their menstrual blood, and then they send it into, there's a couple of different companies across the world right now that are doing this, that they send it in and it evaluates, and it actually looks for the DNA signal of that bacteria or yeast that are present. So it's really cool because it doesn't rely on a culture or having to grow out in a lab for X number of days or weeks, but we're looking at the DNA signature of bacteria or yeast that are in that menstrual sample blood. And where this becomes really important is that I've had lots of women that have gone in and had that hysteroscopy procedure, right? So we're looking at the inside of the uterus. They've maybe had an endometrial biopsy or even endometrial cultures looking for bacteria, and they come back negative. The problem with that type of an exam is that it relies on we're checking the bacteria in the place that it actually is. Now, you might not have bacteria on every single surface of the uterus. It might be in just one small part of the uterus. And so if we're only sampling an area that is normal, we may get a false negative result that says, hey, everything looks fine, but there may be something there. So the beauty of menstrual sample blood is that everything is all kind of mixed together as that uterine wall lining sheds, and we're able to see even small amounts of bacteria that are present within that blood. So the recommendation is to collect menstrual sample blood within the first 6 hours of a full flow, and then ideally collecting it with a menstrual cup or a disc is usually easiest. Then you use the kit that is sent to you, and there's a swab, and you just kind of swirl it around in the menstrual blood and put it back in the vial and then send it away to get the analysis. And what we're finding with this is that even people that have had negative endometrial cultures in the past, we're finding it'll give us an exact readout that says this is the percentage of bacteria that we see, this is the yeast that we see, this is how much lactobacillus or that good bacteria that is present. And that really helps us to discern then what do we need to do for treatment? Because for many, many years, we've known about endometritis, but we just kind of blindly treat it with antibiotics. And for people not in the medical world, that sounds crazy and archaic, but really we kind of just take the best guess. Whereas the sampling and the testing we have now literally will tell us these are the 4 bacteria that we're seeing that are overgrowing, for example, and these are the antibiotics that would treat that appropriately. And so it's really, really helped to fine tune how we treat, how long we treat, and in many cases to let us know, do we also need to treat your partner? So for example, if it's bacteria that normally would live on the skin, we are almost always treating the partner as well. If it's bacteria that only resides in the female reproductive tract, then we typically don't need to treat the male partner. But almost always in our practice, we're treating the male partner as well at the same time so that we're not continuing to pass harmful bacteria back and forth.
I want to circle that a little bit because I think that was a bit of a mind-blowing revelation when I was learning about this, thinking, that woman could restore her health and get right with her bacterial microbiome of her uterine microbiome, I suppose you'd say. But then that her partner could be infecting her if he, in fact, was the one that was carrying an infection of some kind. And that's just mind-blowing to me. And it's something that maybe seems a little bit obvious, perhaps, but not really, because it's not something I'd heard of. But it's like when you hear it, you think, oh my gosh, of course that could be happening. Of course that could be happening. So when these women are getting their results, and like you're saying, they have a breakdown of the certain bacteria that may be overgrowing or the yeasts and these sorts of things, what are some common treatment plans? I know you said that obviously it's going to be different based on the results that these women are getting rather than a one-size-fits-all approach of just a antibiotic that you give and hope it works. What are some different approaches? Is it antibiotic only? Are there other approaches that you take to help restore this issue? I'd love to hear about what you do there.
Yeah, absolutely. Can I circle back real quick, though, to the male factor thing? Because I think that's really important. And I've definitely had a few clients, even within this last year, where when we look at a seminal fluid analysis for a male partner, especially in light of fertility, many people are looking at, okay, what's the count? What's the movement? All of that stuff. And that's about it. And oftentimes we're like, cool, everything is normal. But one of the things that we look at in the field of restorative reproductive medicine is that fertility is not just a woman's game. This is looking at both of you as a couple. And so one of the things that we really hone in on and really look for is what else might be showing up in that seminal fluid analysis that could indicate infection. So if the pH is off, right? So the level of acidity is off. If there's white blood cells that are present, if there's something called agglutination, which is clumping together of the cells. And so I have absolutely had cases, I can think of 2 specifically in the past year, where female factor looked fine, even her charting looked fine, but we actually saw it in the semen analysis. Hey, why does this guy have a bunch of white blood cells? And white blood cells typically show up in inflammation or infection. And so in those cases, we actually will send in the seminal fluid in order to test that for its microbiome. And so in those 2 cases that I'm thinking of, we actually found the bacterial infection was in him. And so this is really, it's beyond just the female factor. And really we need to look at and say, okay, where did this come from and where did it start from? Because sometimes it's not the female we're testing, sometimes we're testing the male. So just another kind of plug for your listeners who are maybe thinking like, oh my gosh, it's just me as the female. No. Like we need to be checking your partner as well, because there are absolutely times where I've seen like, nope, it's actually him that is the carrier for it. And not to put blame on it, but we need to know where it's coming from so that we can treat it appropriately. So when it comes to treating appropriately, there are kind of 3 mainstays that we look at. The first, and I think in my mind, the very most important, is always appropriate probiotics. Now, in our practice, we typically are going to have you do oral probiotics by mouth because, again, it goes back to that gut microbiome. And in most cases, we also will have you doing vaginal probiotics. Now, there are some really good companies out there that now have vaginal probiotics that are specific for lactobacillus. Specifically, Lactobacillus crispatus is the particular one that we should see really in higher amounts in the vaginal and the uterine areas. And so by kind of just loading your system with the good bacteria, we're not just wiping out the bad and saying like, hey, whatever shows up is fine. Like, we really want to set the stage for having the good bacteria present. So we typically time it with your cycle, because part of the other issue is your cycle has different phases that your glands go through. And so we want to make sure that we're covering with antibiotic treatment throughout all of those different phases. So the typical protocol we utilize is we'll start you on probiotics from the first day of your cycle. And again, if we're treating your partner, he follows the same timing as you do. Almost always, we are needing to do something for antifungal medications as well. So we typically will start those on cycle day 2 or 3. Again, appropriate based on what we saw in your sample. A lot of people know about candida infections, or candida, depending on how you were trained and how you pronounce it. But there are other fungus and yeast that can hang out too. So again, we want to treat appropriately based on what other yeast overgrowth might be present. And then typically around cycle day 10 is when we would start antibiotic treatment specific to what bacteria are overgrowing. Now, in our experience, what we have found works best is at least 2 weeks of treatment. And the research in some cases actually supports 3 weeks on antibiotic treatment. And again, part of this is we want to make sure that we're treating through all phases of the menstrual cycle so that we're managing what's happening with the glandular development and making sure that as different things open and as different, blood sample is happening, that we are making sure that we're treating any bacterial infection. The other side of that, though, is that for men, the infection doesn't just live in the semen itself. It actually resides in the prostate gland. And the prostate gland, unfortunately, doesn't have amazing blood supply and typically requires a longer course of antibiotics anytime we're treating a deep-seated infection that may be hanging out in the prostate. And so really what we find is that when we do that 2 to 3 weeks of treatment, we actually approach about 90% efficacy with that treatment course. Now, many women come to us saying, hey, I was diagnosed with endometritis because they saw it on a hysteroscopy. They put me on 3 days of doxycycline. I don't think it made a difference. And I really think this is the reason why, is because we're not reseeding with good bacteria. We're not doing those good probiotics. And in most cases, 3 days is just not going to be enough, especially if your partner wasn't treated. So this is an ever-moving target. So please don't quote me on this forever. If you are listening beyond the year 2026, check the research again. There is so much going on, even in the international community, about how we treat this, what makes the most sense. But as of right now in 2026, this is what the recommendation for treatment is at least 2 to 3 weeks of antibiotics, but always with the probiotics. And in some cases, we can get away with just the probiotics. So for example, like I mentioned, we want to see 99% lactobacillus. If I get a sample that comes back and it says, oh, it's only 90% lactobacillus, in those cases, I'm typically treating with just probiotics because your body is so smart. It will be able to take over and make up for and get rid of the bad bacteria that shouldn't be there if it's not predominantly something else. So there are some cases where just probiotics can be an option as well, because I know some people don't need the antibiotics all the time. But for the most part, that's kind of the general consensus.
It's interesting you walk through this process, how, every phase of our cycle is different and our glands go through different phases. And it's important to capture all of these areas. And again, we're missing that. But that makes me think of, again, a dear friend of mine who has chronic endometritis, was given antibiotics. But prior to being treated, she noticed every single month, this happened like 4 or 5 times, she would get very sick, like flu, every time during her period. And this had never happened before. And it was always like the same day every time. She's like, what is happening? Sick, like multiple days of being out of work. First month, she thought, oh, it's going around. Second month, she's like, that's weird. Third month, she's like, what is happening? And since getting treated for endometritis, because that was in the fall, she hasn't been sick again. There's something about her body reacting to whatever that infection was, I assume, so it's just very interesting. But Teresa's going to ask the next question. But before she does that, I'm going to give a shout out to our podcast sponsors. So, of course, we're talking about probiotics. And did you know that We Heart Nutrition, who is our podcast sponsored. They just started releasing and selling these incredible probiotics. It's very important to have super high quality probiotics, and it's very important to have super high quality supplements. So Teresa and I, we love magnesium glycinate. We talk about it all the time. As a matter of fact, I gave a talk at the University of Northern Iowa in my hometown yesterday, and I encouraged every woman there, please think about magnesium glycinate for your period pain, for anxiety, sleep at night, that sort of thing. So they make incredible supplements. We do that every day. They have multivitamins. They even have vitamins and supplements for men. So I encourage you to check them out. They also give 10% of their profit back to pregnancy resource centers. So they have a heart for the mission, and I really love them. So visit weheartnutrition.com and type in Hormone Genius to get 20% off of your first order. So a special thanks to We Heart Nutrition. Also, Teresa and I, we released a perimenopause program the beginning of this year, 2026. It's right on our website, right on the very front page. But if you are age 35 and up and you're in the crux of hormone mood swings and you're feeling kind of goofy and strange, well, it turns out you may be entering into the phase of perimenopause. Maybe you're deep in it, but Teresa and I have a heart to really help those women who've lost hope to ever feeling like themselves again. And there are days we just feel terrible, and there are days we feel fine. But for those women who are listening and you're like, I just need information, I just need an answer, please consider purchasing our perimenopause course. It's under $100. There are multiple lessons and tips and ways to help ease some of that symptoms, pain, and otherwise. So please check that out. Lastly, and then I'm going to punt it over to Teresa. This fall, I'm offering a hormone coach cohort. Normally, I offer cohorts once a year. So Fiat Institute, we're training a group in the fall, and it's a little bit of an experiment. We're doing things a bit different. If you are thinking about being a hormone coach and you want a discount, and you want it to be a little shorter in terms of the live coaching time, please reach out to me at fiatinstitute.com and schedule a call to talk more about it, because I'm really excited about it. And I can guarantee you there are women listening to this podcast who have a heart to really serve women in the area of hormone health and wellness. So with that, Teresa, I'm going to pass off the baton for you to ask the next question.
Yes. Well, I actually want to start kind of with a case that I had not that long ago, and it was a woman who had secondary infertility. She had actually had 5 children, but then in her, I think probably her 30s, she still wanted another child, and then have 5 years of secondary infertility. And the case really revolved around chronic endometritis. And I worked with her, and an infectious disease doctor actually ended up working with her, because really the source was, these bacteria that are very stubborn. And so I'm going to get Dr. Minjeur's opinion kind of on these like Enterococcus type of bacteria, the aerobic bacteria. They tend to be highly resistant. One that I see, and I often have to deal with this with patients, honestly, just with vaginal infections, especially even postmenopause, Enterococcus faecalis and coli or E. coli that people hear about. These bacteria, like, they are a part of the human body. They're a part of the human microbiome, but then they get in places they shouldn't, and they colonize, and they create biofilms, and then they become highly resistant also to antibiotics. It's hard to get the antibiotics when they do create and form these biofilms. And just remember, this patient, she went to great lengths and, did all sorts of treatments, including vaginal antibiotics, vaginal probiotics, oral antibiotics. So much. But in the end, it was successful. And she actually had a baby almost at the age, I think she turned 46 when she finally had her 6th baby. So, these things I think are very difficult to treat and takes really a lot of patience. And I think a really skilled healthcare professional, someone like Dr. Minjeur, who cares about these conditions. Because if I don't think you really care about it, you're not going to actually put your brain into it and be like, okay, what can we do? How can we get this bacteria out of there, because they create such chronic inflammation, and they also disrupt the immune system's ability, especially when we think of like implantation of the embryo too. So I want Dr. Minjeur to speak to all of this in terms of, kind of really why is this so important to care about what's going on in the uterine lining when it comes to fertility?
Yeah. And you bring up a really good point, Teresa, in that we get pretty good efficacy when we treat based on the specific bacteria, but you're right, there are some that are just a stinker to try and get rid of. It's, it's not like strep throat where we're like, oh, you've got strep, take some amoxicillin and 5 days or so, it'll be gone and you're done. There are cases absolutely where we're like, nope, we need to retest. I think there's still something going on. And one of the beautiful things is that your body will let you know something else is up, right? So you'll either continue to have problems with brown bleeding or spotting or irregularity of the cycles, or, maybe as in the case with Jamie's friend, I feel really sick or it's something else feels really off. And one of the things to remember is that when we have chronic infection, inflammation comes along with it, right? So our bodies are trying to fight off whatever is there that shouldn't be there. And so if there's inflammation that's going on, that's also a really good sign that, hey, something else is not quite right. The only other thing that I can think of to consider adding in is again, making sure that we're helping the immune system. And so in many cases, we do talk about adding in something like low dose naltrexone. Sometimes that can be really helpful or beneficial. There are also studies currently going on over in Spain where they're looking at intrauterine antibiotic infusions. So this is literally you go in, have a catheter placed into the uterus, and they actually apply the antibiotic solution to the uterine wall lining. Now, I can't get any of my patients to sign up for that right now, shocking. But it is something else to think about for sometimes those resistant infections is, we are working on continuing to study these things. I think a lot of it too goes back to, though, how are we supporting the microbiome throughout your entire body, right? Like even though we're treating an infection in one place, we need to be supporting the bacteria, the immune system, the health of your whole system. And sometimes this is where we get into other tricky areas, things like other chronic exposures to environmental illnesses, mold or Lyme disease or dust or environmental allergens, right? Like anything else that might be going on that's really important to consider if we're continuing to deal with these chronic infections. And I think that's why it really is so important to make sure that you're working with a healthcare professional who understands these nuances, and most importantly, who is willing to advocate for you and continue to plug away. Somebody like Teresa, who is like, look, I'm doing everything I can, but I need an infectious disease doctor to help out, right? Like not every doctor is going to do that. So make sure that you're working with somebody, especially if you're having resistant issues, that's going to really get to the bottom of it and say, hey, what else have we considered everything? Is there something else that might be missing here?
Oh my gosh, this is such an incredible episode. You're so smart, Doctor. We know that. We know you're so smart. Actually, how about we take a little side swerve? Can you share with our listeners your involvement with the Institute of Reproductive Restorative
International
Medicine?
Institute.
Yep. International Institute. Okay, so just share with our listeners, like, who are you? What do you do for this, the wider, broader mission of restorative reproductive medicine?
Yeah. So the International Institute for Restorative Reproductive Medicine was founded about 25 years ago at this point in time. And it's really the leading governing body internationally as far as kind of helping to set the stage for what is restorative reproductive medicine, how are we going to continue to advance it, and how do we keep everybody on the same page. And so my role within the Institute is I am actually the U.S. Director of Communications and Development. So part of that role is speaking to the media, going to Washington, D.C. and speaking with politicians, even within individual states. There's lots of states as they discuss different things of how do we get legislation that helps to really support women's health? How do we get good, authentic healthcare that actually makes sense for women and couples? And we are seeing some states that are starting to try and introduce some legislation. So they are contacting myself and the International Institute for guidance on some of those things. And so, there's this side of what I do clinically, but there's also this huge important piece of advocacy in making sure that all women and couples have access to this type of healthcare, to this education, and to make sure that healthcare professionals have access to learning about this education. Because again, as you guys have talked about over and over again on this podcast, this is not education we receive in our regular medical school training, right? And so how do we continue to advocate for that? And so that's really the mission of the International Institute, is to make sure that anybody that wants to receive this education can do so in a meaningful way, and also to help connect patients to healthcare professionals who can do this. And so one of the things that we set up a couple years ago is there is a free service on the website, on the International Institute's website, where patients can go and request access to a registered restorative reproductive medicine clinician. and we can help get you plugged in with somebody who can help you to chart your cycles or help with medical things, because we know there are definitely some deserts in the US as far as it's really hard to find a healthcare professional that has a medical license in your state. So again, that's a free service of the International Institute. So their website is iirrm.org. And at the very top, there's a button that just says find an RRM or connect me with an RRM clinician. And you can plug in that information. It is an actual person that is connecting you with somebody else. It is not an AI bot. So they read those responses to say, hey, who would be the best fit for you that can serve you in that area?
So I know a lot of people might be wondering, if they've never heard these terms like restorative reproductive medicine and what this is. I do think it's getting to be more known, but I still think it's also just like, oh, okay, this is something I'm hearing, but maybe I've heard it a couple of times. I'm not really sure. And then within that also, we have these kind of like, I want to say like other like modalities underneath, like naprotechnology, neofertility, fem medical management. So maybe you can just speak to why, what is the reason there's an overarching kind of theme to this, and what is that? And then give us just a little bit of like a 101 real quickly before we kind of tie up here the end of the podcast of why then are these little like kind of sections of like you can get kind of trained to do RRM, but like with these particular type of organizations that are doing it particular ways.
Yeah, great question. And that's really a lot of what we're trying to do is educate not only the public, but healthcare professionals on this. So restorative reproductive medicine is, I always say it's kind of like an umbrella, right? That encompasses anything that would work to restore hormone health in the realm of reproductive medicine. Now, this doesn't necessarily just have to mean fertility. It can also include anything with your menstrual cycle, with menopause, and both male and female health are covered within this bigger umbrella. And again, that term, restorative reproductive medicine, was coined in 2020 by the founders of the International Institute. Now, over the years, what has happened is there have been different, again, modalities that fit underneath of that umbrella that have said, hey, I have a special interest in this. I'm going to research it in this way, or I'm going to develop this particular pathway. So that's where we see some of these different programs like naprotechnology, fem, neofertility. And honestly, all of them have a little bit of a different flavor, but having received training in all of the methods, they all play nicely in the sandbox together, okay? So the cool thing is if you're like, hey, I want to have more education specifically on how to help infertile couples, neofertility is fantastic at that. If you're like, look, I want an overarching, how do I do all of the different things? Napro is fantastic at that. Fen does a great job of understanding really the why of this. They dig a lot into some of the other things we talk a lot about, like insulin resistance and ovarian aging and menopause. And so really what I tell people that are wanting to learn a method is start with whatever method works for you, but really each of them have their own beauty and genius as far as how they continue to advance the research, how they continue to say, hey, what else is going on in our world that makes sense within this realm? And really being able to kind of look at things with different lenses. I can't say that I would treat one patient with just a napro technique or just a neo technique, because in some cases, the patient needs all of that, right? Every patient is unique. And so having more tools in my toolbox helps me to be able to say, hey, what does this patient need, regardless of where that training came from?
Awesome, Dr. Minjeur. And that's such an important reminder. There are so many methods, but choose the one that works for you. And there are no rules. You don't need to stick with it forever. You can change your mind and do something else later. It's totally fine. So that's such a good reminder, Dr. Minjeur. And we're in this time of history where there's a lot of exciting things happening in the discovery of our reproductive health. We talked this whole episode about this really exciting, interesting new thing that we didn't know about 5 years ago or 20 years ago, whatever. So it's exciting. And what are we going to learn next year and the year after that? So praise the Lord that there's time and attention and restorative reproductive medical professionals who are dedicating their professional life to this effort. So I want to say thank you, Dr. Minjeur, and thank you, Teresa. Thank you both for dedicating your professional life to this. It's so important. So we're going to wrap up here. I'm going to ask you the question. Of course, we've asked you before. We've interviewed you before. So if our listeners are loving this episode, go back and search Dr. Minjeur and listen to the first time we interviewed Dr. Minjeur. But what do you wish every woman knew about her hormone genius?
I don't remember what my answer was last time. So if it's the same, I'm sorry. And at least I'm consistent. But what I would say is that just because something is common doesn't mean it's normal. I hear over and again, women come in with menstrual cycle pain or PMS symptoms or postpartum depression. And they're like, well, my girlfriend had that, or my sister had that, or my mom says just tough it up. And like, that's what it is. And instead, I would offer to pay attention to those signs. They're flags that your body is trying to tell you, and to say, hey, I don't know that I have to suffer with these things. And that's why the work of podcasts like the Hormone Genius are fantastic, because it helps us to understand that not everything that is terrible about our cycle or our symptoms has to be just something that we live with. And in many, many, many cases, it does not mean that you have to continue to suffer.
Great answer. Dr. Minjeur, tell everybody about where they can find you, about all your social media handles. I think you have a podcast as well that you're keeping up with, and about your clinic.
Yeah. So our clinic is Radiant Clinic, and we can be found at radiantclinic.com. We do offer free discovery calls for patients that are interested in services, and we are actually currently expanding into multiple states. So right now I'm able to see patients in 21 different states, and that continues to grow all the time. So our website has all the information about which states we can serve patients in. We are on Facebook as well as Instagram. And then I'm also a part of the Fertility USA board. And so if you're interested in any additional training for neofertility, you can check out neofertilitytraining.com. We do have a spring cohort coming up. So especially if you are a medical professional or if you know one that would like to get training, there is a new cohort coming up that'll be starting here in the spring of 2026, as well as another one in the fall of 2026. And I think those are all the places I'm at. Oh, and my podcast, sorry. My podcast is called Cycle Wisdom. We put out weekly episodes. They're typically 20 minutes or less, and just kind of the quick hits and top things you need to know about any particular subject. If you're interested in learning more about chronic endometritis, I have at least 3 episodes that I've done within the past few months, all about chronic endometritis and other things that may be going on with your menstrual cycles.
Well, thanks again, Dr. Minjeur, for sharing your great wisdom with all of our listeners on the Hormone Genius podcast. We'll be sure to have you back, I'm sure, in the future. So take care.
Thanks for listening to the Hormone Genius Podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel. So if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.